All right, we talked about the sensory cortices in the last area and the lesions that are associated, or the disorders that are associated with lesions of the individual sensory areas. And now we're going to talk about the motor areas. So the primary motor cortex is the source of most of the neurons in the cortical spinal tracts. So the bodies of the upper motor neurons are in the primary motor cortex. So the primary motor cortex on each side, each hemisphere of the cerebral cortex controls contralateral voluntary movements, particularly fine movements of the hand and face. So as you can imagine, in a survival sense, fine movements of the hand and face are pretty important, right? So there's a much greater proportion of the total area of primary motor cortex devoted to neurons that control the hand and face than the whole rest of the body, where more gross motor activity is required. So we need fine motor skills in our hands to, manipulate things and cook food, do that sort of thing, and bring food to face. And we need fine movements in our face so we can communicate with the other humans and live as a society, basically. And we'll see the effects of that from a CVA, how that kind of affects your ability to communicate with the other humans. So it's the same way in the somatosensory cortex. A much greater proportion of the total area of the primary somatosensory cortex is devoted to the hands and face than any of the rest of the body. So it's not just motor, but also sensory. So the primary motor cortex is located in the precentral gyrus anterior to the central sulcus. So just posterior to the central sulcus is the primary somatosensory cortex. So they're neighbors. Isn't that interesting? Neighbors in the brain, and they cooperate on activities in the body. The primary motor cortex is, like I said, where the upper motor neuron soma live. They selectively control contralateral voluntary movements, particularly the fine movements of the hand and face. So selective motor control is important because, like, say that the example they give in the book is typing on a keyboard. You have to press the right key in order for it to make sense. And so you have to have that selective control. The cortical motor planning areas, they are where you plan and organize the movements. So primary motor cortex is voluntarily controlled movements. So if you have a lesion in the primary motor cortex, you're going to have paresis and loss of fine motor control. For the muscles of speech, it's going to cause spastic dysarthria, and we will talk about specifically aphasia and dysarthria and disorders of speech in the next section. So the premotor area is responsible for control of trunk and girdle muscles, making anticipatory postural adjustments. And if you have a lesion in the premotor area, it can contribute to apraxia. And apraxia is the inability to perform a motor task despite intact sensory and muscle movement. You can't plan the movement. A lot of times we will describe this in a chart as having poor motor planning. There are lots of different things, and you'll talk more about this in neurorehab with apraxia. I know when I was studying for the board exam, I kept looking up apraxia because I'm like, what is that? What is that? I don't understand. And I don't think I still understood until I met somebody who had apraxia. And I'm like, oh, oh, that makes sense. So if some of this stuff seems like, wow, I can't even picture that, just wait. You'll be able to picture it at some point. The supplementary motor areas, they work on initiating movement, orientation planning, bimanual and sequential movements, so things that you're doing with both hands or things that you have to do in a movement sequence. And lesions in the supplementary motor area also contribute to apraxia. So you can imagine like say that I'm just going to get dressed for the morning. And I have to do things in a certain sequence. Like I want to put my underwear on before I put my pants on in general. I don't know. Captain Underpants might have another idea, but when I want to get things on right in the right order. And sometimes when you're working with someone with apraxia, you say, okay, let's work on putting your coat on. And you hand them the coat, and they can't even figure out which way is up from where the arms are. So they just can't organize the movement. So that being able to figure things out and figure out the sequence of movements, even something that seems simple, like, oh, get up out of this chair and walk over and sit in that chair, the inability to sequence that movement could really interfere with that task. So Broca's area is a specialized motor area that is responsible for the motor programming of speech. It's usually in the left hemisphere only. So if you have a left hemisphere lesion in Broca's area, you're going to have Broca's aphasia. And we're going to talk more about that in the next section as well. So it's a motor speech disorder, difficulty organizing the motor movements of speech. The interior frontal gyrus, usually in the right hemisphere in the area analogous to Broca's area, is responsible for planning nonverbal communication. So emotional gestures, tone of voice. If you have a lesion in that area, then you have difficulty producing nonverbal communication. So the way this presents in the clinic is a very flat affect. Someone seems very emotional, like you tell them something, they're not going to get excited about it. They're going to be very flat. So when you work with people who've had a right-sided stroke, they often have left hemiplegia and that flat affect, because their nonverbal communication is affected. Not only do they have difficulty producing nonverbal communication, they have difficulty understanding nonverbal communication. So there's a lot of stuff going on there. Interesting, right? So damage to the primary motor cortex is characterized by contralateral paresis and loss of fractionation of movement. So if you have the lesions on the right side, your left side is going to be affected. If the lesion's on the left side, the right side is going to be affected. Dysarthria is a speech disorder resulting from spasticity or paresis of muscles used in speaking. So we said in one of these, you're going to have in primary motor cortex lesions, you're going to have spastic dysarthria. So spastic dysarthria is hypertonicity of the muscles of speech. So you have harsh, awkward speech. Flaccid dysarthria is paresis of the muscles of speech. So you get breathy, soft, imprecise speech. So in the next chapter, we will compare the different types of dysarthria and dysphagia and aphasia. So the cortical motor planning areas are anterior to the primary motor cortex, and the three areas that are in that section are the supplementary motor area, which is important for the initiation of movement, orientation of the eyes and head, and planning bimanual and sequential movements. So I'll say knitting. So like it'd be hard to knit if your supplementary motor area wasn't working. And for a lot of other things probably too. The premotor area controls trunk and girdle muscles via the medial corticospinal neurons. And Broca's area is responsible for planning movements of the mouth during speech and, interestingly enough, the grammatical aspects of language. So how we put words in the order that we normally put them in. So I've worked with a lot of people who have Broca's aphasia, and it is very interesting. And when we talk about aphasia, I will tell you some stories. It'll be fun. So premotor cortex lesions impair the speed and automaticity of reaching and grasping. sequential movements, and gait and posture. So I worked with a gentleman a while back who had a stroke that affected his premotor cortex. I'm assuming by the difficulties that he had. Um, and it was an anterior cerebral artery stroke, so it also affected his personality. But he had that trouble with that reaching and grasping and doing things, whatever. So we were doing some things in the clinic where he was standing because gait and posture was also an issue and sequential movements. He was standing and we had him standing at the counter and stacking cones, moving things from one place to another, trying to get that reaching and grasping and the sequential movements and the gait and posture, the posture when you're standing. Well, his wife thought, well, that's a good activity that we could do at home. So she bought a set of like plastic cups that were different colors, and she would have them she would have him sit there in the kitchen and stack them and restack them and make patterns with them and do all sorts. So she came up with this all on her own, which I thought was very clever. And he enjoyed the activity, so he used to do it a lot. And it really made a difference. It improved his function a lot. She said once he got good at it, of the moving and stacking the dishes, she started letting him load and unload the dishwasher because it was a similar movement. And he loved it because he was able to do stuff around the house. So it just shows you how like little things that you can do in the clinic can translate into functional movements and make a big difference for people. So I thought that was a great activity. And having a supportive care partner when you're recovering from something like this is the difference between success and failure, really. So motor planning area disorders, apraxia, also known as motor agnosia. So remember the sensory agnosias, even though you can recognize, you get the information, you can discriminate between different sensations, you can't recognize what they are. So basically, with motor agnosia, you lose the ability to perform skilled movement. So you can't sequence movement like buttoning a shirt or brushing your teeth or something like that. Even though you have the physical ability to do it, you don't have the knowledge of how to perform that skilled movement. Can you regain it? Yes, with a lot of practice. But it's still difficult. A motor perseveration is the uncontrollable repetition of a movement. So you can have physical perseveration where you or motor perseveration where you like say you lock and unlock the brakes on your wheelchair like over and over and over and over again. You could also have verbal perseveration where you say the same thing over and over and over again. And I've definitely worked with people who have that, both of those things. Sometimes you can break someone out of perseveration by changing the activity. So you're changing the sensory input, changing the activity, and that breaks them out of that perseveration. If you're going to direct them in specific tasks, it's really important to be able to do that. So, or sometimes doing some dual cognitive on motor dual tasking can help break someone out of motor or verbal perseveration. Broca's aphasia is difficulty expressing oneself using language or symbols, and that includes writing. So speaking, vocabulary, grammar, and the physical act of writing are all affected in Broca's aphasia. So you think of writing as being a purely motor task, and it's not. It's motor, cognitive. There's speech involved because it's basically a visual representation of speech. So Broca's aphasia affects a lot of things. The association areas of the cerebral cortex are any area of the cortex that is not directly involved with sensation or movement is called the association cortex. So I don't know if anybody's old enough, but when I was a kid, they always used to say like, oh, you only use 3% of your brain, which is not true. use all of it. But the areas that they were saying you didn't use were the association areas. So they weren't associated with a particular sensation or movement. But yeah, you do use it all. Absolutely use it all. So the signs and symptoms of a stroke, any stroke, are going to depend on the location and the size of the lesion. So we talked about all those different areas and how lesions in the different areas might affect the function. And this is from the last PowerPoint. This is the same slide. Now you can see hemiparesis is obviously the motor cortex is going to be involved. Ataxia, cerebellum. Hemianopia, the visual cortex. Visual perceptual defects, probably visual and somatosensory cortex are involved. Aphasia, it can be any parts of the speech, motor speech areas like Broca's, it could be dysarthria. We'll talk about some other types of aphasia. Sensory deficits, if the somatosensory system is involved. Memory deficits, if the memory system is involved. Problems with bladder control, interestingly enough, are associated with damage in the frontal lobe. So now going back to this, having looked at the areas of the cerebral cortex, you can see how damage to an individual area might cause these type of symptoms. So recovering from stroke is a long-term thing. It's not like you're just going to recover right away. A lot of it depends on how much of your brain was affected, how much of it is because of edema or intracranial pressure, how early you got treatment, which areas of the brain are affected. There's a lot of controversy about whether you should teach compensatory movements, try to rehabilitate the actual area, try to influence motor controls. There are lots of different approaches to stroke rehabilitation. There's a lot of research that indicates intensive task-specific therapy produces significantly better motor function compared with the remediation approach. So the remediation approach is trying to retrain certain functions. If you do task-specific therapy, so in the one study that was cited in the book, that people on average of 3 to 4 months post-stroke significantly improved on several measures with a task-specific program combined with patient self-identification of their own problems. That is super important compared to someone who received a conventional remediation approach where somebody just said, here's what you're going to do. So if the patient says, I'm having trouble with this specific task, or their care partner or family members say that. So for example, I talked about the person with locked-in syndrome. When he was becoming more functional at home, one of the tasks that he wanted to be independent with his showering and everything. So one of the tasks that he had difficult with was stepping into the shower. He had a walk-in shower, but there's a lip that he had to step over. And he had grab bars and he had all the tools that he needed, but he needed to practice the task. And so we practiced that task. We simulated it in the clinic by using parallel bars for a grab bar, and then his wife measured the height of the step, and we had a step that height, and we stepped over it and stepped over it and stepped over it and stepped over it a lot of times through multiple sessions, and he got to where he could do it independently. So that task-specific, self-identified task-specific is really important. So that's not just the case with stroke, but with anything, any rehabilitation you're trying to do. If the task is salient and important to the person who's doing it, they're going to get more out of it. So help your patients by having them self-select, self-identify things that they want to get better at. They're going to be motivated to do things that they want to get better at. So I worked with a lady a while back who had a stroke, and she had previously been a knitter, and she wanted to knit. and she had some effect in one of her hands, and we just said, let's try it. Let's just try it. And she we were working on, of course, gait and balance and all those other things. And I found this video on YouTube for a technique for one-handed knitting. And so I gave it to her, and she looked at the video and she goes, "Oh, that's interesting." So she started trying one-handed knitting, and she did this at home. We didn't do this in therapy, but um, she tried the one-handed knitting, and the more she did it, the more her other hand started participating, and she kept doing it, and she got to back to where she could knit at a pace and a speed and a tension that was acceptable to her. And so if it's important to the patient, they are going to work on it. And how much they work on it is going to affect how well they recover. So I think it's really interesting. One thing about working with stroke patients you're going to find is a lot of them really are very focused on, I want to get back to exactly how I was before, and they are never going to get back to exactly how they were before. They're going to have to establish a new normal. They can improve their function as much as they can and as hard as they want to work, but they're never going to be, nobody is ever going to be exactly where you were before. So, but working on task-specific therapy with patient self-identification of their own problems, they are going to get better results than if we assign things to them.